It is my honor to introduce the speaker for today. Dr. Richard Cash is a senior lecturer on global health at Harvard T.H. Chan School of Public Health. Dr. Richard and his colleagues conducted the first clinical trials of oral rehydration therapy, ORT, in adult and pediatric cholera and diarrhea patients at the Cholera Research Laboratory in Bangladesh. One of the major interests of Dr. Richard Cash is scaling up health programs, and he is the senior editor of From One to Many, Scaling Up Health Programs in Low-Income Countries. He has also documented the scaling up of the BRAC ORT program, a simple solution. As a member of BRAC Health Group, he and his colleagues have documented the BRAC TB DOTS program in making tuberculosis history community-based solutions for millions. It is pertinent to mention at this juncture that one of every 100 children in India does not live to celebrate the fifth birthday because of diarrhea, and India accounts for a quarter of the world's TB burden, and on average, 1,000 persons approximately die because of TB every day in India. Dr. Richard Kash worked with BRAC on their OTEP, which taught over 13 million mothers and caregivers how to prepare and use ORT in the home using the pinch and scoop method. It is estimated by WHO researchers that each year around 500 million packs of oral rehydration solution are used in more than 60 developing countries, saving over 60 million lives around the world. And in 2006, he was the recipient of the Prince Mahidol Award, and in 2011, he received the Price Prize for Improving Health. It is our pleasure to hear from you today, sir. We extend a warm welcome to you in this Public Policy Talk series. I would not take any more time in keeping everyone who are waiting to hear from you.
Thank you very much for those kind introductory comments. And it's a pleasure to be back in Bangalore, however virtually it might be. I was there in early January to give some talks at a workshop at St. John's. So it's nice to be back, even though virtually. I thought what I would do is to look at scaling up of health programs, and also as embedded in this is how incentives were appropriately used. And what I've chosen to use this as to use the BRAC experience as a model for what might be, what has occurred, and what might be. And I hope that this will generate a lot of interesting questions. So let me start by, let's see how I need to move this forward. There we go. So who is BRAC and what is it? It turns out BRAC is the world's largest NGO with over 100,000 employees, and both in its workforce and its outreach. It began in 1972 in post-war Bangladesh. The mission has always been to work with poor people to bring about positive changes in quality of life through a holistic approach, a very pro-poor and a very strong focus on empowering people. Sir Fazli Abed, who just passed away in December at the age of 83, was very fond of saying, small is beautiful, but big is necessary. They are in over 70,000 Bangladeshi villages with expenditures of over $1 billion, of which 80 to 85% is generated by BRAC itself. They are also in 11 countries and have been rated the #1 in terms of quality and so on NGO in the world. As a disclaimer, I should note that I am on the board of BRAC USA and have been associated with them in various guises since its founding in 1972. Now, let me just start out by reviewing what the lessons for scaling up are. First of all, it's multidimensional. You need to commit to scaling up from the very beginning of a program. So you have you have to have an institutional vision. In this case, it's to alleviate poverty and to create equity. It's important that pilot programs with relevant research and evaluation be carried out, and workers are trained prior to the scaling up, not as an afterthought. Management needs to be appropriate, very down to earth, and strongly supervised. Evaluate, adopt, and advocate, and consider a more realistic long-term frame. Oftentimes people think in terms of 1, 2, 5 years. They think in terms of many years. So the first program I'm going to try to give uh, uh, some idea of how these come together is the BRACS DOT program for TB treatment. Now, DOTS is short for Directly Observed Therapy, short course for TB treatment. It's the standard used throughout the world, including India. When they began their program, they faced two problems. One, how do they identify cases early? Because the longer someone is not identified, the more likely they are to spread the disease. And since this treatment of DOTS requires 6 months, there was a lot of people who would drop out as soon as they started to feel a little better. And the concern here is that drug resistance would develop with people dropping out early. So the challenge was how to identify cases of tuberculosis in the community, not a passive, that is, where people would come to the clinic because they were feeling bad, but active, going out into the community and actually identifying cases to ensure that treatment was begun early and that treatment was completed. So it was begun, and both of these examples are historical, but are ongoing, and so I think it's highly relevant. It was begun in 1984 and 85, which was their trial programs in a sub-district with a population of 220,000, using what were called and are still called Shastik Shebekas, a village-based volunteer. Clinical cases of TB were identified using a very clear algorithm. That is, someone had a chronic cough, maybe a bloody cough, loss of weight, and so on. And this was done through active surveillance. So these Shastik Shebekas would visit houses as part of their otherwise routine and identify cases. And then they would collect sputum specimens. The diagnosis at that time, and even now in most areas, is through staining of the sputum and looking at the microscope. And then they provided a community-based treatment, directly observed treatment. So what was the program? Well, it was based on door-to-door service by the Shastik Shebeka. So she went to the house itself to provide the drugs. Now, here is one of the innovations, and I hope we have some discussion on this. To participate in this program, the individual had to put up a financial bond prior to treatment, or about 200 taka at the time, around $3 US, which was returned on completion of treatment, less a fee for the worker, but forfeited on noncompliance. And there were very clear guidelines as to what was noncompliance. If you stopped taking the medicine and you didn't give a reason, that would be considered noncompliance. Now, treatment was never denied because treatment was always available at a government facility, which was within a certain distance from the village. The Shastik Shebeka got a small incentive for finding cases and completing the treatment. Supervision and quality control was carried out by another group called the Shastik Kormi, who had 10 Shastik Shebekas under her control. And there was then a further layer of evaluation and supervision by another level up. There was support both from government and from donors, and I will explain that. So the requirements of a bonding system: one, it has to be community-based. Treatment is generally delivered by non-professionals, since you don't, although it could be ASHA workers, certainly. The community or program contributes the bond if the patient is too poor. So no one is denied treatment because of a lack of money. So the community, generally, BRAC did not contribute to the bond. The community put up the bond if the patient was too poor, so that nobody was denied treatment. Treatment is clearly combined with education, because the Shastik Shebeka goes to the house and also inquires as a member of the community what is happening. There's a reliable backup healthcare system to handle any complications. So any complication would be referred, and there's frequent supervision and excellent management. So who is the Shastik Shebeka? She's a health volunteer, usually around 35, with children selected by the villagers. Literacy is preferred, but not absolutely required. They're trained to recognize and treat common diseases such as diarrhea, acute respiratory infection, including TB, and they also sell and distribute certain other products such as material for headaches and so on, and things of that nature. They provide basic healthcare services to about 300 households or around 1,500 individuals. So here's some pictures, and I use a lot of pictures in this. Here is a Shasta Shebeka in an urban slum area, having collected sputum and labeling it to be sent for testing. Here is a worker giving drugs to somebody in the community. The worker is the one with the bag. And again, she's observing the individual taking the medicine. So for the first few months, it is directly observed therapy. After that, then a week's supply is given, and so on, after the person has been habituated into taking the drugs. They come together usually once a month for a few hours as a refresher course. And here's a group of Shasta Shebekas who have come into a BRAC center for a continuing education. This is a picture from Afghanistan. BRAC, one of their countries that they also do work in is Afghanistan, in addition to Sierra Leone, Tanzania, Uganda, Kenya, and so on. Here, it is given through a pharmacy, where again an individual is treated right there. And later on, they set up TB DOTS corners in some of the hospitals and clinics, again, where this was distributed. What are the results of this program? Well, and these are older data, but it's held true. 92% cure rate, about 0.3% failure, 4% death. Now, this is the next, is very, very important. Only 1.3% default. So over 98% are staying in the program. The cost is lower than the Ministry of Health. In 2006, the National TB Program and BRAC expanded DOTS to cover over 100 million people with 78% case detection and treatment success up to 94%. Now, what factors then contributed to the success of this program? And this is true with many of their scaled up programs, not only in health, but in agriculture, education, their graduate program in microfinance, and so on. You learn from a pilot program with independent research and evaluation. BRAC has a whole department called Research and Evaluation Division, which is separated from the rest of the organization so they can act independently. In this case, the involvement of community health workers was very important, with an incentive system for case finding and completed treatment. The patient provided a bond for reliable services because the drugs are free of charge. So nobody is paying for drugs. The only thing that they're paying for is the services provided by the Shasta Shebeka. The treatment is simple. It's right at the doorstep. There is strong management and the availability and use of external technical assistance. So if there are problems, that is bumped up the system and other advice is given. In fact, this program was an outgrowth of a program that was advised by a Japanese consultant and who helped BRAC set this up from the beginning. Let me now move to another program called OTEP, or the Oral Therapy Education Program, which again features an interesting management tool. Diarrhea was and remains a major health program, although mortality from diarrhea has come down globally very dramatically in Bangladesh and in India.